with your leadership, so Dr. Herzog chaired a FDA consensus panel. He and I and others, we felt that if we were going to bring drugs to you, that we had to get agreement with the FDA. What are the endpoints? So he chaired a panel that said that progression-free survival is an acceptable endpoint. It used to be it had to be survival, but we all agree that these patients are living a long time, post-progression survival is long, and that led to the FDA approval in June of 2018 of bevacizumab. It was approved in 2011 in Europe, but we had to get past this with Dr. Herzog's leadership to PFS. Tell us about that FDA approval of bevacizumab.
Well,
a year and a half ago.
Yeah, it was over 1,800 patients approved in frontline. As you said, we had previous approvals in platinum-resistant based on the Aurelia data, and then based on Oceans and GOG-213, we had approval in platinum-sensitive. So, impressive hazard ratios, right, in the recurrent setting. The hazard ratios are not as robust in the frontline setting. So people argue, well, should I use it up front? Should I wait and use it? And people have that argument all the time. We've had 2 subgroup analyses, one from ICON-7, which looked at a lower dose for a shorter period of time, but nonetheless showed a subgroup that truly benefited from having Bev on board. And then we had a subgroup analysis with 218, slightly different criteria that showed a benefit. Basically, the high-risk patients, again, 3-4, ascites, those widespread carcinomatosis, the ones that we knew were going to recur. But what we're learning is most of these patients are going to recur anyway. So I'm not sure there's a low-risk advancst stage ovarian cancer population.
So in September, JCO, again, last author, 10-month improvement in overall survival for stage 4s. I get it that that's this, and remember, I'm the expert here. I learned the technique, exploratory endpoint, definitive conclusion, cross-trial comparison. I'm joking. But there is a consistency of the data between ICON-7. Do you buy that large volume tumors do better with bevacizumab?
Well, I think so, and in my practice, I always use it if there's any component of significant ascites and certainly pleural effusions and large volume disease. I find that it helps those patients significantly. Those that start with large volume ascites,
they're in trouble and they need it.
They're in trouble, and it's amazing how fast they can dry that up. So,
so ascites, as we've talked about before, is angiogenesis out of control, because these new blood vessels are not completely tubularized, and they extravasate fluid into the peritoneal cavity. That's ascites. So it sort of is a surrogate biomarker for angiogenesis out of control. And I agree with that. I probably use a little bit more bevacizumab than you. But again, we've been in this since June of 2018.
It's been a moving target, though, in terms of prevalence, because it was under 20% before the approval, and now it's certainly gone up significantly.